Apparently, the organizing committee thinks Dr. Haugen is one of the most effective teachers we've ever seen. So we've asked him to tell us about immunotherapy in 10 minutes. So this is like a game show, I think. So even I've heard him lecture a lot. I'm interested to see how he pulls this one off. Good luck, Dr. Haugen. Go.
Thank you, Dr. Tuttle. You just took 10 seconds off of my talk. So my disclosures are here. I'll talk a bit about a trial that is supported by Eisai and Merck. Another disclosure, I am not a tumor immunologist, but I do play one at the World Congress. And the third disclosure is I only have 10 minutes to give this talk. So broadly, immunotherapy can come in many different flavors. A lot of work has been done in cytokines, vaccines, and then there's cell-based therapy, dendritic cells, now macrophage-directed therapy, and what I want to focus on is T-cell therapy in this talk, but letting you know there's many other immunotherapies out there. I think this is a nice summary in a breast cancer journal looking at three main types, what's called cell transfer therapy, which we now are doing a lot more work in these tumor-infiltrating lymphocytes, and others are doing work in this area. Cancer vaccines that by themselves have pretty much not worked, but maybe in combination are going to be better. And then the immune checkpoint therapy on the anti-tumor immunity, which is what I want to talk about more, targeting these T cells and their checkpoints. The other point I want to make is we're also adding back in things like cytotoxic chemotherapy and radiation to help with this immune response. And what I believe in the future, this is sort of a summary slide, that we're going to be using combinations of these in patients. Maybe tumor-infiltrating lymphocytes or CAR T cells plus checkpoint therapy or plus vaccine therapies using 2 or 3 different vaccines. I think that's what we'll be seeing more of in the future. So again, the checkpoints, I think we all know that when a T cell is activated, it turns on, it brings many of these molecules to the surface that are called these checkpoints, such as programmed death 1 or PD1 and CTLA4, and there are many others, TIM3, LAG3, there are just many of these. And then what happens is that's turned down, so we don't have this autoimmune response. Tumors have now used that to their advantage to basically make the immune system exhausted for this. And the reason we consider these checkpoint inhibitors either against things like PD1 or CTLA4 or the receptors such as, the ligands such as PD1 and PDL1 and PDL2 is to break that tolerance. And this just shows one example of a drug called lambrolizumab, which is now pembrolizumab, and I'm not quite sure why they changed that name. This was in melanoma, and this just shows once again a patient who had a dramatic response in the mediastinum in the liver with this therapy, and below that you see these are infiltrating CD8 cytotoxic T cells. And then this is that waterfall plot we've seen with many other things. These were heavily pretreated patients. And this is really a dramatic response that they got. They had a 10% complete response, 36% partial response. There are adverse events with these, though, as we know, and I'm going to, again, focus more on the PD1 and PDL1 therapies. There are many papers. This is just a more recent meta-analysis. We worry about things like colitis, hepatitis, and pneumonitis.